All right. Well, thank you again for the invitation and for being here and being part of this great discussion today. So I am John Elias from Cleveland Clinic, Akron General. So I am a modeler by trade, basically, and experience. I'm going to talk a little bit about bridging the gap for models from reliability to relevant. And this might seem like it's a little bit of a critique, but it's all from a family member who's like coming from a place of love and I'm a believe in computational modeling, but I think that there are things that we need to do to make it more relevant to our clinical problems. So, I generally my research focuses on patients with knee disorders, more young athletes and younger people than the older populations. But we're really looking at for people with traumatic and non-traumatic knee disorders. And Dr. Spindler can correct me if I'm wrong, but when these patients go to see their provider, whether it's a sports medicine doctor or surgeon, the main priority of the patients and oftentimes the surgeons too is how do we get them back to function, back to work, back to playing their sport. Maybe they're up for a scholarship, maybe they're a professional athlete or whatever. How do we get them back to do that? And to do that, a lot of times it's about stabilizing the knee if there's soft tissue injuries and reducing pain. And if you can do that, you can get some good, short-term outcomes. You get back to people doing the things they want. But oftentimes that overlooks what the longer-term goal is, because we know a lot of these knee disorders also create the risk of osteoarthritis, ACLs, patellar dislocations, and so forth. That's pretty well shown. It could be as high as 50% within 10 years. So how do we achieve both goals to get patients back to return to play, but also preserve their cartilage long term? If you can see this video here, if this will play, this is an ACL rehab video that somebody put on YouTube. So raise your hand if your model can represent this. So patients that knee function that's related to injuries, and a lot of times patients coming back from injuries and the type of activities they go to is dynamic.
John, I hate to interrupt. I couldn't see how many hands went up. I'm just
just Ahmet. He's got it all figured out. We're just riding along in his wake.
Send me that model.
Yeah.
I'm sharing it publicly.
I want it now.
So when patients have injuries and they go back to function after injuries, their type of motion they're experiencing is dynamic. It involves high-level impact. It's multiplanar. They're not moving in one plane. External forces are applied to the knee. It's also repetitive. So, and these patients are fatiguing their muscles and they're fatiguing their soft tissues. A lot of times injury happens, doesn't usually happen the first play of the game, right? People are they're developing microtrauma in their soft tissues. Their muscles are getting fatigued. And that's what contributes to injuries a lot of times as well. And our models don't really, don't always account for that. Plus, we've got to figure out when our patients come in, they don't necessarily have normal knees. So they usually have pathologic anatomy. The patellas are often, their knees can be malaligned. They might have existing cartilage deformity. A lot of times they have ligament laxity. We see that a lot in the patellofemoral world. And they could have micro injuries as well. It's like I said, little fatigue injuries that happen. So this is just some examples. Patients from some of our various studies with patella alta, patella malalignment. This is actually even after surgery. We can have a fissure on cartilage in the preoperative condition, a little bit of inflammation. This is one of the ACL patients that has a little bit of fibrillation there that we can see already developing at the patellofemoral joint. So these are things that we also have to account for. Not only that, as we mentioned, and we sort of mentioned in passing, but we haven't really talked about a lot, is the biological effects of injury. We know this is a knee after dislocation that has a big effusion. That inflammatory response to injury itself is detrimental to cartilage and soft tissues. And we need to understand how our models of mechanics interact with inflammation. This is, and I'm going to show data from a lot of studies. I'm not going to go into them in a whole lot of detail, but sort of like, trust me when I say what some of these results are. But basically, this is a representation of some of our patients with patellar dislocations, where we can look at cartilage properties for control subjects and how they're influenced by BMI in patients who in the acute phase of a dislocation and they go in the opposite directions. So the mechanical signals that are influencing the cartilage properties are different for a healthy knee and a knee that's just experienced a traumatic injury and in the midst of an inflammatory response. We also know that these knees can recover partially from injury. That's this graph here shows some of our subjects evaluated at acute time periods, and 6 months later, there is periods where cartilage can recover partially. But we also know that factors such as nutrition can definitely influence the recovery process and how you respond to inflammation. We already talked about sex a little bit, and then even within sex, the hormones, within like especially women with the reproductive cycle, the hormones within the system can definitely affect the biological response to mechanics and how they all interact to cause injuries and recover from injuries. So what are the implications for computational simulation? Are our models of stable motion, are they relevant for dynamic modes of injury? Is the validation and reliability assessment that's performed with normal anatomy, is that suitable for pathologic conditions? How do we account for patient-specific tissue properties? And when are the biomechanical factors relevant and how do they interact with biology? Because if we're modeling biomechanics, we need to know that it has something that's relevant for the response of the subject. So how do we address these issues? One is we can improve a representation of dynamic motion, develop patient-specific models, been talked about quite a bit. Statistical shape modeling for variations in anatomy, we've talked about a little bit in the last couple of days. Quantitative MRI, we haven't really addressed much, but that's a great tool for assessing properties of tissues and looking at inflammatory effects. We can look at load-bearing alignment as opposed to unloaded alignment from supine MRIs, and then investigate the biomechanical and biological interactions a little bit more. This is actually Don is probably familiar with this. He's helped with some of these studies, but this is a validation versus patient function where we're including weight-bearing alignment from a weight-bearing cone beam CT scanner along with different MRIs, unloaded MRIs, which we can then all kind of merge together with different in-house programs based on AI that helps you characterize for this subject where the cartilage is loaded, what the deformation is, how the knees are aligned, and so forth. That gives you a lot more information than you can get from just a supine MRI. If we want to look at dynamic injury models, this is some people have talked about multi-body techniques as opposed to FEA. This is a dynamic injury model that I developed a while ago, published a few papers on where we're using multi-body dynamics to actually look at injury mechanisms. So it's unstable motion is difficult to do with FEA, and it doesn't give you the fidelity and resolution that you'd want, but maybe in some situations it can answer some questions that you couldn't get with more stable models. Statistical shape modeling, these kind of tools give you ability to represent anatomy and how anatomy changes from healthy knees to injured knees that we can introduce in our models to look at the global effects of different the global change from healthy to injured, as well as try to map anatomy to individual patients. Quantitative MRI. So quantitative MRI is valuable for characterizing things like inflammation. You can try to characterize inflation based on diffusion. You can look at for bone marrow lesions and look at sizes for those, as well as the common features of looking at using quantitative MRI to look at cartilage properties. In this case, this is T1 row data where the red areas are high T1 row values, which are representing relative low concentration of proteoglycans, which then creates relatively poor cartilage properties. So red in this case is areas of concern. And you can also do these with like T2 star imaging. You can also look at properties for ACL, PCL, and patellar tendon that we can then incorporate these updated properties in our models to make them more representative of the individual patients as opposed to using generic material properties for these tissues that might be related to injury, fatigue, might be related to the preoperative condition, and so forth. The biomechanics biology interaction, this is, again, data from several studies. I don't need to go into all of them in detail, but what they're really showing is for different populations, we've got patellar dislocation patients, patellofemoral pain patients. The stage you are, we already showed data on injured versus uninjured knees, and the response to anatomical parameters like patellar length, the body mass parameters, Other things like age depends not just whether you're injured or healthy, but what phase of your injury that you're in. So if we look at patients in the acute phase of injury, we already showed this graph where they have the opposite response with BMI, but 6 months later, and these are actually all the same people, 6 months later, inflammatory effect starts to wear off. They start to move back to maybe the relationships that start to get neutral, and then maybe eventually later on will move back towards the relationships that a normal knee would have. With age, we see inverse relationships between T1 row relaxation times and age for patellofemoral pain versus control patients. And then in different stages of injury, we can also see them respond to anatomy differently. So if we don't know where the biomechanics has an effect, then we're providing data. We could be providing data that really isn't relevant to the overall performance of the patients. And this is where we need, if nobody else is going to tell us when our models are relevant if we don't, or at least assess when our models are relevant if we don't. There are other approaches that you can use. Biomarker studies are valuable. Proteomic studies, we talk about motion capture, wearables, large databases, longitudinal outcomes, all that kind of stuff are also helpful to refine our models, make them more relevant, make them better representation of the injured and the recovery conditions. But there's certainly many more ways to evaluate things. So how do we develop relevant computational simulation? The easy thing is, well, let's just apply to mechanical concerns. Let's just look at studies related to stability, range of motion, total knee design, that maybe we know these are mechanical issues. We'll make mechanical model and we'll just study that way. But that kind of narrows our scope and limits us to some stuff that doesn't really address the big picture issues. What causes early OA and what causes patients to need these treatments. We're kind of limiting ourselves from doing those kind of studies if that's where we limit our analysis to. We can represent activities and tissue properties that lead to injury and degradation a little bit better by maybe making having different types of models for more dynamic activities. Again, identify conditions where the biomechanics is the most relevant to function and degradation, so that we can be confident when we tell the surgeons, look, in this phase, we know the biomechanics has an impact, and this is our model. So we're not giving them, we're not giving parameters to shoot for that are not relevant, right? So if we're doing that, we are decreasing their confidence in us because they're not seeing it in their outcomes. And that sort of puts us in a position where people don't trust what we're doing with computational modeling. So the overall goal is to use this type of tools, quantitative MRI, all these other simulation, other types of analyses, biomarkers, whatever, to identify patients at risk of injury and develop optimal treatment strategies for short-term function, short-term outcomes, and also a longer-term joint preservation, which again, big goal. It's not easy to achieve, but if we don't aim high, then we'll never get there. So that's really all I have. This is the PAMI group. We need an analysis from our funding agencies. I sort of hijacked this picture, but really the brains of the operation is here. This is Zhao Li here in the white baseball cap. And I've been very fortunate that she has let me hang out with these very bright and talented people for the last 7 or so years, and just play around with all these different ideas, as well as the collaboration with orthopedic surgery here at Cleveland Clinic has been great. People like Dr. Spindler and Dr. Farrow and Dr. Saluan who've contributed mightily to these ideas and the data we generate, that just sort of taken somebody who's just sort of in an outpost down in Akron and just trying to figure out how to do some things that are relevant, and kind of put me in an area where I can feel like we could have some big impact on the way orthopedic surgery is practiced. So that's all. Thank you.